Good morning, everybody. We're going to get started. Welcome to PCH Grand Rounds. This morning, we get to highlight our residency program and some of the outstanding work that they do in their advocacy projects. Dr. Christy Samaddar is going to be our MC this morning. I'll welcome her in just a minute, but she is one of the associate program directors for our pediatric residency program and is the director for the advocacy track curriculum. So please welcome Dr. Samaddar.
So presenting our residency program's advocacy outreach has been something that's been a tradition at Phoenix Children's Hospital for many years. Many of you, or some of you, know Dr. Sarah Bodie. She took on this project and was a great mentor to a lot of us here, including me. And I have since carried it on as she's left, and I wanted to keep it going where we present and highlight some of the work we're doing in the residency and at PCH at large. As you will see, a lot of us, even outside of the residency or in other specialties, do a lot of amazing advocacy work. From the title, you can see that it's a team effort. Obviously, there are a lot of people that are involved. I have no disclosures, but I did want to point out, we all do the modules if you're employed by PCH that says that when you do advocacy work, unless you've had permission that you've expressly got from Phoenix Children's, you're doing it on your own behalf as an individual and not on behalf of Phoenix Children's. So I have 3 learning objectives. One is to emphasize the importance and the historical perspective as pediatricians as advocates. The second is to highlight some of our current advocacy initiatives, both in the residency program and the hospital at large. And the third is to teach all of us, no matter what role that we play, ways to be advocates in our work. So I want to start with a case. There's a 12-month-old boy who's transferred to the ICU for refractory progressive pneumonia and nodular skin lesions. When you look back at his history, since 7 months of age, he's had recurrent severe upper respiratory tract infections. He has some lab work done when he's admitted to the ICU, and it shows that he has a very high white count at 45,000. His hemoglobin and platelets seem somewhat unremarkable, as does the differential. But because of his history of severe infections, he has a little bit more thorough workup, including immunoglobulins, which all classes are quite low. And he has flow cytometry, which shows that he has very low T cells. Any ideas? I will make you call it out. This is a case of severe combined immune deficiency. And this is a face that, at least if you were born around my age, you probably recognize or have heard of. It's David Vetter. He was the boy who spent his 12-year life in a bubble trying to prevent pathogens from the outside world coming in because he had severe combined immune deficiency. This natural history of this disease causes many, many infections and is usually fatal by the age of 2 years if untreated. What does this have to do with advocacy? Well, as of January of 2017, Arizona was standing out, but not for a very good way. We were one of 3 states who did not screen for severe combined immune deficiency as a part of our newborn screening process. As you can see, or if you look, the Navajo Nation, which is separate from Arizona, was including this in the newborn screen, but the rest of Arizona was not. And it is somewhat interesting to me because in Arizona, we have a high population of Hispanic and Native people who have higher rates of SCIDs or of SCID than the general population. So it seems like something we would want to be screening. It's important to screen like other newborn screening diseases because if you pick it up early, there are things you can do differently. You should not give the rotavirus vaccine because it's a live vaccine and it is dangerous to people who have a compromised immune system. If you transplant kids with SCID before 3 months, they have the best outcome. And early detection does decrease morbidity and mortality. So a group of people that you probably know well from Phoenix Children's Hospital, Drs. Wright and Dr. Bauer, also felt that this was important to change. They started on a project that I learned about through Quality Day, in which they wanted to estimate the incidence of SCID in Arizona in particular. They wanted to engage stakeholders, and I listed them out here, including Phoenix Children, the Arizona AAP, University of Arizona, tribal health councils, a lot of local community providers, the Arizona Health Department, and on and on. They gathered a big team because they wanted it to get added to the newborn screen. They knew that if we added it, we needed to have a plan if we were picking up positives. So they developed, they wanted to develop an algorithm for managing it, an infrastructure for treating the kids that they would pick up. And they were able to accomplish it. So as of now, we know the incidence of SCID in Arizona is 2 to 4 cases per year. We have it added to our newborn screen as of this month. And there is a toolkit that most of those pictures that I included in the previous slides are from the toolkit. And it's on the Arizona Department of Health website. So I think the work that they did really highlights how to be effective as a child advocate. What you need to do is you need to decide exactly what you want to happen. You need to find out who has the power to change this. You need to understand what are motivating factors for the decision maker and what are barriers. You need to tell your story. People making change really respond better to how it's going to impact an individual or the face of what you're trying to advocate for as opposed to statistics. You need to find partners, and they found a really large group of partners to advocate for this change. You need to give credit to the people who depend on credit to get reelected, as opposed to doctors who really don't want to be in the limelight too much. Politicians count on getting credit for making positive changes. And you need to celebrate small successes because in advocacy work, sometimes they're few and far between. So that's what I wanted to do with that case, because that's something that's really made a big, or is going to make a big impact going forward. The other thing I'm sprinkling through here, just because I'm a former English major and I love inspirational quotes, and all of the people that I've included are advocates in our country or pediatricians who are advocates. So if you want to lift yourself up, lift up somebody else, says Booker T. Washington. The historical perspective of advocacy is really that pediatricians have been advocates from the get-go. If you look back to the person who's considered the father of pediatrics, Abraham Jacobi, he wrote a paper that basically said women and kids are not small and different men, and that we should have our own specialty, and then started advocating for pediatric health from the get-go. And then I won't read all of them, but as you can see, the AAP was formed and started advocating from the 60s for increasing access to care for kids. Many of you might recognize Kip Charlton. He's a local advocate who had a long storied career at Maricopa Medical Center, and he started the crisis nursery advocating for protecting kids from violence and building stronger families. And he's a role model for a lot of us here. And then even more recently, as we were presented at a conference, Nadine Burke-Harris created a Center for Youth Wellness, advocating for screening, the influence of adversity on childhood long-term health outcomes. So you can see from the get-go there are many pediatrician advocates. This is a pediatrician from the 1920s who was seeing kids in pretty bad situation in the Industrial Revolution. And he said, if you today have a broader vision of your science than the men of 25 years ago, it is not because your sight is better, but because you stand on their shoulders. Advocacy, simply put, is speaking out on your patient's behalf. It assumes there's a problem that needs to be fixed and a way to fix it. A lot of pediatricians feel that, or people feel that they really can't be an advocate because there's not enough time and there's too many responsibilities, that they haven't been trained properly, that it's confrontational, and people like me shy away from confrontation, that it's political and they don't really want to get into the political arena, that it can be fruitless or frustrating, or they feel powerless to make change. And those are real barriers, but there are some solutions going forward. There's an advocacy guide that the AAP has published that helps you stepwise approach. Think of how you can do it in little bits and pieces, and I've included a lot of their teachings in this talk. And then there are these training modules that one of the child advocates that I highlighted created a whole curriculum called Community Pediatrician Training Initiative. And these are different spheres of advocacy that you can do for free through the AAP and get better at working with partnerships or being a legislative advocate. There are many different types of advocacy, and I just highlighted this framework for thinking of it. There's clinical, community, and legislative advocacy, and so I'll highlight some of the things that we're doing in each of these spheres. Clinical advocacy is practicing with an awareness of a larger vision. That your patient comes to you in the context of a family or a population group, and you're working to continually improve your practice to serve them better. So things that we do here that fall under this realm are all the things that we do for quality improvement, and that's a whole different talk, but I'm a part of that as well. And I'm really impressed that we had 53 different projects that were submitted to Quality Day this year, and so that shows that we're really passionate about doing quality improvement work as advocacy. If you screen for social determinants of health and try to help your families overcome disparities, then that's clinical advocacy work. And then there are things that we do that's called stealth health, and that means where you're trying to promote a health message, but you're not preaching, you're not in your patient's face about that, and that's such things as using the walls in your clinical space to promote healthy messages, having injury prevention notices and drowning prevention week and things that our hospital does to try to get our whole community healthier. And usually with these things, if you make the right choice, the easy choice, it's easier for families to accomplish it. So one of our resident groups took on increasing HPV vaccination rates as a quality improvement project and posted these posters highlighting that HPV vaccine is actually cancer prevention. And that's been motivating to help a lot of our families overcome their fear of getting the vaccine. And these posters are in all of our exam rooms in the Gen Peds clinic now. The social determinants of health, there are many validated tools that you can use to screen for that, and this is one of them called We Care. And it's fairly simple. It's just, do you have this issue, and if so, would you like help getting resources? William Carlos Lois Williams was an early pediatrician and also a famous poet, and he said, "One thing I'm convinced more and more is true, is that the only way to be truly happy is to make others happy." Group advocacy is identifying a group and working to improve health and decreasing disparities within that group. And our hospital has a whole department, our whole division called the Homeless Youth Outreach that focuses on this. And it takes the mobile units out to communities where they would have poor access to health care. We also have some community partners. Mack Elementary School we've been working at for many years, which I'll highlight, and the UMOM transitional home and homeless unit or shelter, we have a strong connection and do many clinical and group advocacy outreach with them as well. So the second one I want to highlight a different case. A lot of us have seen a patient like this, a 6-year-old Hispanic male with a BMI greater than 99th percentile, acanthosis, presents for a weight check, and the weight has gone up, as you can see in the left corner, or the BMI has gone up. And when you dig a little bit deeper, they don't feel that they have a safe place to play outside of their house. They don't have a car, and the grocery store is not really easily walkable to. However, there are many pulperias, many corner stores that sell junk food and sugary drinks on almost every corner, too numerous to count. And unhealthy food is served by the school, according to the mom. That when you dig into the family dynamics, there are many power struggles over eating. The mom tries to buy fruits and vegetables when she can, but she has trouble getting her kids to eat them. And they have low confidence in their power to change this situation. So a group of residents went by and walked this community, and this is what they found in walking around. So the dangerous neighborhood does seem to be quite true. There are big holes. This neighborhood is not somewhere far away. This neighborhood is next to us. It's just across Highway 51 from the hospital. And this is a school in that neighborhood that we've developed a relationship to. It's called Mack Elementary School. For the past 4 or 5 years, we've been working with them. A catch grant was obtained by Dr. Bodie to do a community needs assessment there, then followed by a health fair, helping get access to care for the families that go to that school. And last summer, they were able to form the Mack Collaborative Community Center and keep their playground open to help have a safe place for kids to play in that neighborhood. This year, we were able to partner with the Injury Prevention Department and bring the Triple P Parenting Program to help with some of the family dynamic issues that I was bringing up and help parents feel empowered to be positive yet still disciplined. That program is 8 weeks long, and we had over 10 families participate in that 8-week program. We also have ongoing talks with a very dedicated group of moms and dads who come, and these are some of the topics that we presented: positive discipline, diabetes, wellness and stress reduction, and how to prevent and treat common pediatric illnesses, and when to seek care. And now I'm going to introduce Jen Farabaugh, who leads up the Pediatricians at the Capitol, to talk a little bit about legislative advocacy.
Good morning. Pediatricians at the Capitol started in 2014 as a resident-driven initiative. We had a group of intern residents come in and ask us to start this legislative event. It's focused on teaching residents the legislative process, and we usually do 2 events each year. We have had great success with it, and it's in collaboration with the AZAAP. Since 2014, we've had over 140 total participants, and now, as of last year, it's a statewide initiative where we're inviting residents from the University of Arizona and community pediatricians through the AZAAP. This past year, we had 42 participants, and we do a pre and post survey every year to assess their comfort level and knowledge of the legislative process and initiatives in Arizona. Only 16% knew who their state legislators were before the event, and 100% know afterwards. We overall annually get a rate between 4.5 and 4.45 out of 5 for the event every year. And 95% to 100% of the participants feel that it is an important or very important part of their annual training as pediatricians. We often have legislative representatives come and speak with the residents, and we had great success this past year. The AZAP outlines legislation that we follow throughout the year. So we followed the GDL law, which increased the age of banned communication devices to 18, so that children learning how to drive in Arizona cannot use any type of communication device, either to talk or text, until they're 18 years of age. And then the skid fee cap was raised this past year, which we followed. And we had an ACE legislation introduced this year to look at ACE screening and the potential impact and resources that we can provide in the community. We have outlined our event dates for next year, so if you're interested as either a community pediatrician, resident, or other participant, please keep an eye on these dates of February 1st and February 28th.
So as a part of the residency program administrator, it came to light that we as boots on the ground doctors may not be aware of what our hospital is doing with planning their advocacy work. And so I wanted to use this opportunity to bring one of our senior strategic planning associates, Robert Douthett, to come up and tell us a little bit about the process about how Phoenix Children's Hospital chooses its advocacy mission and how it does the community health needs assessment.
Sorry about that. With the Community Health Needs Assessment, we partner with the county and all of the other health systems in the general area. Banner's involved, Mayo, Honor Health, all of them. And what we do basically is, this is a requirement from the Affordable Care Act in 2017. Do that. And what it requires PCH and all the other health systems to do is to define the community served, define the needs within those community, and then also to document what our process is going to be to meet the community needs, and to develop implementation strategies on a 3-year cycle to meet those community needs. We partner, like I said, with the county they collect a lot of the data so that we don't have to kind of duplicate efforts across health systems. And so we come together and we try to, as a community of health systems, define the needs that are in the community, and then additionally, once the county has provided that data for us, we take it internally to our stakeholders and we ask them, of these needs identified by the county, which is it that we feel that PCH needs to address most? What are the highest priority needs amongst our patient population? And in prior years, we tried to handle all 8 of them, and this is kind of the system that the health systems did the first time around. It was the first cycle, so everyone was like, we're going to try and handle all of the needs that the community decided on. And what we did this year is we tried to prioritize and get to the ones that our internal stakeholders decided were the highest priority needs amongst our population, those being access to care and mental health. In response to that, we had obviously Dr. Samaddar had talked about Dr. Bodhi and the shadow she's cast in this organization, but with her absence, Dr. Riccardi and Dr. Bernatavicius, I hope I say that right. Okay, not very good with names. They stepped in and they took those initiatives, and they came ready to kind of push forward initiatives that they thought would best address some of these issues, especially when it comes to access to care and behavioral health. This cycle will go from 2017 through 2019, and for the purposes of the IRS, we have to report on how we are developing those, the implementation strategies we develop, and then how we are progressing on those year over year. So basically, one of the things we try to do with this is to align this with the strategy and a lot of the programs and initiatives we already have in place. We don't want to recreate the wheel, but in this sense, it does inform our strategy also in terms of how we're meeting those needs. So we believe, obviously, with the information we all have and the data that come to us from our doctors and any of the stakeholders, that we're trying to address those needs. But the county process basically helps us align those with what the county and what the community says they need from us. So it's kind of helps level set where we are and make sure that we're addressing the needs of our patient population. That's about it.
And then next we have Jonathon Gonzales, who is the director of the Center for Family Health and Safety. This group was formerly known as the Injury Prevention Department, and they still do a lot of that work, but I hadn't met Jonathon yet, and I'm not sure if a lot of you have, as he's relatively new to the organization. And this department helps implement some of the hospital's needs assessment goals. And so I wanted you to meet him and have him say a couple words.
Good morning, everybody. A lot of enthusiasm this morning. So thank you, Dr. Samaddar. I learned a lot this morning about the advocacy in pediatrics. Hopefully I can tie this all together for you. When you heard Dr. Samaddar talk about advocacy, she went down the different pillars of advocacy from the clinical side all the way up to, for your patients, all the way out to doing work at the state capitol. And so you also heard this morning from Rob about the community health needs assessment and how that's critical in giving us a level reset and understanding what's happening within our own hospital system and how we can address some of those community needs, or what we call social determinants of health, right? We heard that earlier today, and I'm sure all of you are familiar with that. But there's some connecting pieces that I think are really critical for not only the work that you all do, but what we do at the Center for Family Health and Safety. I have a staff member and colleague, I'd like to say, Allison Gilbert, who is one of our triple P providers. Allison, if you can wave your hand over there. So what Allison does now is working for the Kohl's Department Store grant, which is called Mindful Me. And this program really focuses on a couple of different pillars related to mindfulness, so trauma-informed yoga in the classroom, some community school gardening, and then the triple P parenting. There's some other components, but I won't get into the weeds on that. So that's one of the initiatives that we're doing through the Center for Family Health and Safety, along with all the other injury prevention stuff. And so why this is all connected to your work and really critical in terms of advocacy is because when we talk about the needs assessment, what happens is, unfortunately, much like a lot of health assessments that are out there, whether it's a CHA through the community health departments, Department of Health Services, or this CHNA, it's a deficit model, right? So the deficit model says, here are the things that are not going so great. But for those of you that are doing community-based work, for those residents like that went out to Mack, you may have a pulse on the community, both through working with your patients or through some of the clinics, and really get a sense, if you're doing some of those surveys around social determinants of health, to be able to inform the process. So that's the small a for advocacy, right? That's not at the state capitol necessarily, but it's informing policy making in a way that's very pertinent and very relevant. And so when we talk about the needs assessment that's happening, and if you want to participate in any of those processes, the county is going through a county health improvement plan, it's also called the CHIP. And in that CHIP process, when Rob was referring to the level reset, a lot of the data and information comes from community folks and providers. So if you have spare time on a day or your off day, if you want more information about that process, that's another way you can be involved in terms of advocacy, because you lend a certain perspective in working with patients and going out in the community. So I would welcome you, if you're interested in to hear more about what we're doing through the Center for Family Health and Safety, or getting involved in some of those work groups of the county, you can approach myself or Rob, but I always welcome those folks who are working directly with patients to be there and to be a voice.
So, as you can tell, there are a lot of passionate people who are leading the charge with advocacy, not in the least our residents. We have, for the past 2 years, a track where you can specialize your curriculum with advocacy work. And we have both second and third years who are on this path. The third years are here, and they're going to share the work that they have done and what's in progress to still be accomplished throughout this year. So the first to call up is Himali Bhatt, and she is going to talk about her project on assessing residents' comfort in managing pediatric patients who have had traumatic experiences.
Hey, good morning, everybody. So I'm working on a QI project with Dr. Samaddar, and what we're doing this year is that we're assessing residents, essentially working with patients who've had traumatic experiences. So it's a pretty pervasive topic for everybody who works with children. So the background of the story actually starts with ACEs. So that was what Jen was talking about earlier, about the new bill that's gotten introduced into our legislature here. So there was a groundbreaking study, one of like the newest epidemiological points actually, that was done in 1998, and it was cohorted by the CDC and Kaiser. And it was called the Adverse Childhood Experiences Study, and when shortened, it's called ACEs. And what it did was that it highlighted the role that ACEs had on long-term morbidity and mortality. Essentially, just a little quick rundown on the background of the story. What led to this was that 17,000 patients at Kaiser filled out a survey about adverse childhood experiences they had experienced as children, and what their provider had found, Dr. Folletti, one of the founders, was that he was running an obesity clinic, and he kept losing patients who, despite having lost weight, would still not continue to follow up. And so he talked to them and was trying to figure out, you know, what the root cause of this was, why they weren't succeeding in coming back. And he learned that a lot of them had undergone abuse as children, and that's what led to this study. So essentially, the ACEs showed that there was actually chronic health conditions that resulted from prolonged exposure to certain types of episodes. And that included things like ischemic heart disease, COPD, STDs, increased risk of suicide, smoking, having cancer, and diabetes, all profound things that we now are facing as pediatricians and that manage all of our populations in adult healthcare. And what they also found was that there was a dose-dependent response. So the more ACEs an individual reported, the more chronic medical conditions they had as well. I'm going to come back to the second point in just 1 minute. So the Adverse Childhood Experiences Study defines adverse events into 3 categories. It's not just like running away from your friend who's playing tag with you at school or taking a test or auditioning for something. It's something that has a long-lasting impact on you. And so the first one was abuse, and that was delineated into 3 categories of physical, emotional, and sexual abuse. Then there was challenges in the household, which was defined as observing violent treatment of the mother in the home, like domestic violence, substance abuse, mental illness in the household, incarceration, and separation and divorce of your parental figures. And finally, there was neglect, which was defined as emotional and physical neglect. So coming back to this point now, there's now, as a result of this study, there's been many studies that have come out of this study, and they've been recognizing that there's actually a really important factor in having trauma-informed care to help increase patient health outcomes. And that's where trauma-informed care comes in. So trauma-informed care is a framework that is available for both providers and for patients. And it kind of falls under four things. So the first is to realize that trauma is very prevalent. This study actually found, the CDC and Kaiser study found that there was over at least 60% of all adults had experienced one of these ACEs studies. So it's pretty profound, and they've actually found that in children and youth it's even more pervasive than it is amongst adults. And then the thing is that trauma is prevalent, but then the important thing in trauma-informed care is that there is a way to recover from this. And then the next thing is to recognize that there's trauma that exists in your patient populations and amongst the providers that are caring for them. The next thing was to take this information that you've learned and to respond to it. And the whole goal of trauma-informed care is to resist re-traumatization and to break the cycle that people are stuck in. So that leads to the QI project. This year, we're studying the impact that trauma-informed care training is going to have on residents' awareness of ACEs and their comfort in managing patients who have experienced adversity. So earlier this month, we actually had our trauma-informed care training as part of our block conference. And prior to this training, the residents completed a pre-training survey, and then we'll be completing a post-training survey at the 3 and 6 month periods. And often people ask, why pediatric residents? This key study was done in adult healthcare, but as pediatric residents and those working with children, we're at the forefront of witnessing both firsthand and learning about the ACEs that are encountered by both families and children during our visits, during our time in the hospital with them, just talking to them. And they've actually found now that the earlier you intervene in addressing these exposures, it actually improves outcomes for patients to recover from it. So that's why it's extremely essential that residents learn about trauma-informed care. It's becoming one of the new buzzwords for pediatric trainees in the section of pediatric training at the AAP, actually. And so our results are, of course, still in process right now, but what we have at the moment is that we had a 67% response rate with 80 of the residents out of the 119 responding, and it was actually a good split amongst all of the classes, including the PGY4 Med-Peds residents. And so stay tuned for more information as we have more of those results for you. Thank you.
So our second resident speaker is Ashley Smeeting. She's going to talk about her project on improving adolescent healthcare.
Good morning, everybody. So I'm one of the third-year residents. So basically, my advocacy project involves around improving the care that we're delivering to our adolescent our adolescent population at the pediatrics or the PCH Gen Peds clinic. And basically, with the help of one of my friends and colleagues, Gabe Rosado, I don't know if he's here, but we did a global assessment of how we're delivering care to that population within our clinic and developed strategies to improve the care that we're providing and then also expand upon the ways or the things that we're already doing pretty well. So why does it matter? So as you all know, adolescents are a unique population. They have ongoing cerebral development. Their prefrontal cortex is not yet complete, and they're at risk for risk-taking behaviors and the morbidities and mortalities that go along with that. Unfortunately, what's been studied and found and shown is that few are actually receiving adequate preventative counseling and screening, even though most of us have the best intentions, of course. And a lot of that is partially based on the patient, so patient factors, but a lot of times it's healthcare providers that have identified barriers, so whether that be institutional type barriers or personal barriers. And then also there's, just based on history and studies that we have, it seems as though there's not thorough or adequate clinician training. And that's kind of where we come in, especially as pediatric residents and having a program where we can kind of expand upon that and help to improve that. The YAHS is a survey that is used amongst multiple states and organizations, specifically in several states. Medicaid uses it, and it's a survey that actually asks adolescents how thorough, essentially, their health care is that they're receiving. And specifically for risky behavior topics, it's as low as 18%. So teens are reporting that 18% of teens are reporting in those studies, or in that study, that they have been asked about risky behavior topics, compared to 50% for diet, weight, exercise topics, which are far easier, I think, to address, given the just with comfort level for between various providers and patients as well. So it has been shown that teens are actually interested and willing to talk with clinicians, so it is something that we can pursue and we can do better at, because they will talk to us if we provide them the right opportunity. So our mission, basically we had 3 goals, and they're you'll notice they're very broad goals, overarching. It's meant to be like a long-term sustainable process that's not all meant to happen right now. But basically we want to improve the teen experience. So we sent out through the adolescent doctors, so Dr. Beaumont and Dr. Huddleston and Dr. Chulani, we sent out a teen survey that the teens completed at the end of their visit. And we want to increase the amount of teens that are either very happy or happy with their clinic visit by 20%. And then also I held a focus group several months ago that talked about, the teens talked about their experiences and what we could be doing better, what we were doing great. So between the survey and the focus group, trying to improve the amount of teens that are happy with their care. And then also improving resident confidence and consistency in providing adolescent health care. So we sent out a resident survey that most of the residents completed, maybe about 60%, and how confident they were in discussing adolescent issues. As we all know, it can be uncomfortable, like I mentioned, to address some of these issues with adolescents, how we actually do it, what words we use, our body language, all of that, getting parents out of the room, to have private conversations with our teens. And so one of our goals is to increase education in terms of adolescent care and their confidence. And then ultimately, throughout the years, our goal would be to increase well-child check rates as a measure of both of these. So improving comfort and continuity between the patient, the parent, and the clinician. So these are driver diagrams that we've created for each one of those goals. So on the left-hand side in the blue is our aim, like our global aim, and then our specific mission, those 3 that I had just mentioned. And then each column to the right is like the drivers and the intervention. So the ones here in the green are the actual interventions that we have proposed, and then they affect the boxes to the left to ultimately improve or achieve our global aim. So I'll talk about a few things that we've done so far. So a couple things in terms of improving the percent of teens that are happy with their care. We are talking about making teen-only exam rooms, so there's appropriate brochures and information for teens, and also, we get rid of the toddler toys and things like that, so teens feel more comfortable in the rooms. And then also providing information in the end of visit that teens get, so that it's standardized between all residents and providers. So teens will get healthcare information or like websites, resources that they can have in their hand before they leave their visit, and that's kind of standardized amongst all providers. Specifically for the residents, I think that's something where that we're kind of focusing on right now, and I think it's going to have a lot of impact because we are all learners and we're a captive audience, so we can do a lot of training. This Thursday during our block conference, we're going to be discussing adolescent health care, so specifically confidentiality, consent, teens' rights, and then how to have these conversations and provide more of a standardized way of going through things in hopes to improve the confidence of residents. Specifically also like outlining policies for when to have the confidential visits with teens, at what age do we start the private heads exam, and then improving the template, our note template actually, to make sure we're hitting the key points and we're addressing those issues that cause the highest morbidity and mortality. And then, like I said, dot phrases at the end of the visits and providing additional resources for residents so we don't feel lost in adolescent care. And then these are some other things. They kind of are duplicate for our aim of increasing well-child rates, but just providing appropriate handouts in regards to adolescent development, also discussing with parents what they should be expecting, like we do with a 9-month-old well-child visit. We talk about what they should be expecting and what to expect in the coming months. So helping parents understand their teen's development as well. And then also a big thing is looking at our actual physical space within the clinic and making sure it's adolescent friendly. So making sure we have posters that outline the policies and rights of adolescents so they're aware that they can get their confidential health care here. And that's about it. So like I said, not all things that need to be done at once, but these are hopefully ideas that can be sustainable over a long period of time, and we can kind of as a clinic go back and look at where we are and where we can improve, and then this can provide a platform and pathways through which to go if we want to continue to make improvements.
This is one of my favorite authors and poets, Maya Angelou. She said, "I've learned people will forget what you said, people will forget what you did, but people will never forget how you made them feel." Our next and final resident speaker is Lauren Boddilly, and she's going to talk about her project.
I'm also one of the third years, so my advocacy project kind of took a little bit of a pathway on its own. So I had started off with a different project and kind of learned about working with different partners outside of the system and how difficult that can sometimes be. But during my community month is really when I kind of started developing this passion for working with our homeless youth outreach. So during that month, there we go to all these different homeless youth outreach programs and sites, and all of the kids there first get kind of an initial physical if they're staying at that site. But not all of our kids are utilizing the healthcare system, our mobile units, as well as they could be. And so basically my overall goal is to figure out how can we increase utilization of our current services and what additional services we can provide to our transient youth. So essentially, why is this important is Arizona has a pretty high rate of our homeless youth population. And so this chart here shows essentially where a lot of our homeless youth are actually living. And so if you look at it, about more than half are doubled up, so meaning that they are living with other family members or other family friends, kind of in the same facility, but they don't necessarily have their own house. You have 28% that are in foster care, which is a unique population itself. That's also in the sheltered population, and then we have 4% that are staying in hotels, and then 3% that are completely unsheltered. That means living on the streets. So Arizona ranks 17th in terms of homelessness, and overall, as I mentioned, we have a large homeless population, particularly in Maricopa County, which is obviously where our hospitals are based that we go to as residents. One of the things that kind of got me interested in this was during our community outreach month, we do a project, and I was researching a bunch of different homeless youth, kind of how they access care and what are their utilizations. Sorry about that. And one of the things that Eric Rice does is he looks at a lot of the different homeless population in Southern California. And one of the things I thought was interesting is that 62% of homeless youth in Southern California actually have a cell phone. The reason why I thought this was interesting was because what happens is a lot of times our patients will come to the mobile unit, we'll see them, and then we don't necessarily have a great way of getting back in contact with them to maybe tell them their results of, say, like STD testing. And the ways that we know to get a hold of them are either just to keep showing up like we do, which, every week we show up at certain sites, and they know that we show up there. But we also try to reach them through any sort of cell phone contact that we might have with them, and also through internet use. So we do have MyChart through Phoenix Children's Hospital, but we know that even in our general pediatric clinic, we don't utilize it the same amount. So what I was interested in is how can we kind of increase use, particularly through electronic use, because a lot of our homeless outreach sites have internet access there, and we also have patients that will go there and hook up their cell phones and share each other's cell phones, and how can we kind of increase outreach through that way as well. And then several studies kind of showed how often they access electronic health care and what are they looking for when they're doing using their electronic use, and then where do they do it. So public, libraries is one place, but again, youth agencies like our homeless youth outreach centers are also a very popular place. So, as I mentioned, essentially identifying what are barriers. So we've been handing out 5 question surveys. They're very brief. And then the last question, well, the last 2 are open-ended, one being just anything that you can think of that we didn't ask about that is a barrier to healthcare. And then the very last question is basically, how can I reach you if you're interested in a focus group, which is our next step. So we have had pretty good success in terms of handing out these surveys. And the 5 questions are essentially, what are barriers? What are your access to health, to electronic use? And how do you want to get your healthcare information? And then also, how do you want to save your healthcare information? Another issue with our transient youth is that they might receive care at one place, but they might go somewhere else, and they don't have their electronic medical records in one place, which there are a lot of different programs that are looking at bigger cities. So, for example, in Chicago, they have an app that homeless youth can log into on their mobile unit, and they can actually figure out where open beds are for shelters, where can they receive certain health care, what's the cost, and that sort of thing. Other sites are using, for example, in Santa Clara, California, they actually just have a clinic, like our mobile unit, where then they basically train adolescents that utilize those services to enroll other kids in something called Health Shack, which is an online medical records system basically, where then they can upload, with permission we can give them their records, and then they can upload their own, and they have an online filing cabinet essentially for all of their information, including things like Social Security cards and so. So overall, that's just kind of where we're at. Right now we've been at 2 different homeless youth outreach sites. And like I said, pretty much everyone that goes in there when I'm there for a few hours in the morning, if they don't want to participate, then the people running the youth site usually yell at them and tell them to fill out my survey for me. And then we've also done a catch grant application, so we're waiting to hear back for that as well. So kind of overall, we're just in the beginning phase of this, trying to figure out where we can go from here and how we can help our transient youth.
So as you can tell, we have a really impressive group of residents who are working on many different projects. So I just want to close in the last few minutes with hopefully inspiring you for ways that you can get involved as well. The first thing is just to simply know your population. As you can tell, a lot of the projects focus around focus groups and kind of knowing what the issues are for a certain population. You can screen for social determinants of health in your programs where you work. You can screen for ACEs. You can do a window survey, which just means drive by your community where you practice and see some of the things that your patients are facing. Once you get an idea of what's going on with your patient population, find what the problem or your passion is for advocating for change. Is the patient that you're seeing in your continuity clinic or in your practice having a problem that's part of something bigger that could be addressed? There's many different ways to get involved, so I'm going to highlight just 3 different sizes of advocacy that I call Tall, Grande, and Vente. So if your career is busy and you have a lot of different obligations, choosing the Tall is a great way to go. So vote, that's the first thing. Participate in Pediatricians at the Capitol and learn a little bit more about legislative advocacy. Contribute to a political campaign or a nonprofit advocacy organization that your passion aligns with. Patronize businesses that contribute to children's health issues. Or create a local list of resources that you might use in your practice or send to your employee group or professional society that would help benefit everyone. The Grande version is write a letter to the editor of a local newspaper or your Arizona AP or other professional society to highlight an issue that's important to you. Meet with a decision maker at your place of work or community. There's a lot of different things that we could be passionate. There's one initiative called Healthier Hospitals about making hospitals greener and serving healthier foods. If that's something that's interested, that might be something you would bring to the forefront, or get involved with the Quality Improvement Project. As you can tell, there's a lot going on that could use your help. Join a task force through these different organizations. And then the Venti approach is complete the CPTI training on the website if this is something you want to incorporate as a part of your career. A lot of pediatricians here, including Dr. Bodie and Dr. Notrika, have testified before state legislature to help pass things like the child booster seat laws and things like that. We depend on that for moving things forward. Serve as a spokesperson for a local issue or community organization. Or, as you can see, we have a lot of passionate residents and could use help mentoring some of their projects or tagging them along in a community advocacy project that you have. And there is funding for this through the Catch Grant through the AAP. So lastly, the greatest of all mistakes is to do nothing because you think you can only do a little. Thank you. If you have any questions, we have a couple minutes. Otherwise, thanks for coming.